One of the issues with headaches and migraine in children and adolescents is there's a lot of treatments that are approved for adults that have not been either proven effective for children or adolescents or are lacking evidence. And so approximately every 10 years, there's a review of the guidelines. So there's several different guidelines. The purpose of guidelines is really to not only identify what the current state of the knowledge is in terms of recommendations for doing studies and treatment in both acute and prevention of the headaches, but also to identify gaps that we need to fill. So what I'm going to review is really the development of those guidelines. Part of it is, and there's actually 5 different publications based on 3 of the guidelines. So the first one is really, that comes from the International Headache Society, was on how to do preventive studies in children and adolescents. And Dr. Albarfe, Dr. Diener, and Dr. Tessori and I put this together really to sort of outline so that as preventive studies, or whether it's acute medications or preventative medications or devices are used, when they're used for prevention, how to properly do the studies so that studies can be comparable from one to the next. Then the next 2 sets were a revision of the previous guidelines for the acute treatment of headaches in children and adolescents, as well as the preventive treatment of headaches in children and adolescents. This was co-developed by the American Academy of Neurology as well as the American Headache Society, and co-published in the Neurology Journal as well as the Headache Journal. And then some of the key guidelines that did come out of this were then summarized in an editorial that followed this in the American Headache Society. But the bottom lines were that a first-line agent for most children and adolescents would start with an NSAID, or non-steroidal anti-inflammatory. Typically ibuprofen, but naproxen sodium could also be utilized. We do avoid aspirin in children under 16. If this was not effective, then the consideration of adding a triptan could be considered. If this triptan was not effective, then adding another triptan could be considered effective. And the triptans that had the best evidence for that included the sumatriptan, or a combination of sumatriptan and naproxen sodium, as well as rizatriptan, which currently in the United States is approved down to age 6. Zolmitriptan nasal spray was also identified, and in my talk I'll review the tables that came out of these guidelines that are available in the publication. The preventive guideline then looked at what agents would be useful for prevention of headaches in children and adolescents with migraine. This guideline did identify there were lots of gaps in our understanding. The evidence of the highest degree that was for the prevention included amitriptyline plus cognitive behavioral therapy for the prevention of chronic migraine. Other suggestions were that medications such as cinnarizine, which actually is not available in the United States but available in Europe, flunarizine, topiramate, and may also have some degree of efficacy. But the key that came out of this study was there still remains lots of gaps, which makes that first guideline, how to do a preventative study most appropriately, is essential so that we can hopefully fill some of these gaps.